Good morning. Again, my name is Dorina Stashek from the New England QIN-QIO, and I will be your moderator for today's webinar, More Music, Less Medication. Thank you for joining us for today's webinar hosted by the New England Quality Care Collaborative in partnership with the New England Rural Health RoundTable. Before we get started, I'd like to review a few housekeeping items. This call will be recorded for training purposes. I'll provide you with details on accessing the recording at the end of the webinar. Phone lines will be on mute for the duration of the presentation. We'll take a few questions at the end of the presentation. If time allows, I'll provide you with instructions on how you can ask a question over the phone at the end of the webinar and through chat. If you have a question during the session, you can post it directly in the chat box at the bottom right of your screen. Make sure to send all your questions to all participants so we can keep up with the incoming messages. I put a link into the chat box to download today's webinar presentation. At this time, I'm going to mute all lines.
The leader has muted your line. To unmute your line, press #6.
6 to unmute yourself. You'll need to wait about 10 or 15 seconds to switch over and speak. Okay, at this time I'd like to introduce our speakers. Sarah Duraniak-Dudley, Senior Program Administrator from the New England QIN-QIO, will get us started. Then we'll hear from Annette Blanchard, Director of Nursing, Miranda Thayer, Assistant Director of Nursing, and Alita Potts, Staff Development Nurse. The latter three are from the Franklin County Rehab Center in Vermont. I'll now pass things over to Sarah to get us started. Sarah?
Thank you, Doreen. On today's webinar, the team from Franklin County Rehab in Vermont will present on their journey to improve dementia care with their residents. They'll give helpful tips for successfully implementing a music and memory program that reduces antipsychotic medication use in persons with dementia, along with identifying key challenges and successes with implementing the program and steps for sustainability. Now, before I turn it over to the team at Franklin County Rehab, we wanted to provide a brief background on why reducing antipsychotic medications has been such a focus within the nursing homes and other healthcare settings. Antipsychotic medications, both atypical, also referred to as second generation, and older typical first generation antipsychotics, are indicated to treat conditions and diagnoses like schizophrenia and bipolar disorder. This includes atypical antipsychotics like Abilify, Risperdal, Seroquel, and Zyprexa, and first-generation antipsychotics like Haldol. While there are no FDA-approved antipsychotic medications to treat dementia-related psychosis, delusions, and hallucinations, they are frequently prescribed off-label to treat these symptoms. Some of the risks of using antipsychotics in persons with dementia include serious side effects, including dizziness, sedation, and delusions. There's an increased risk for hospitalization and potential for falls and other adverse events, including increased risk for pneumonia, stroke, and death. It's important to know that while clinicians have the option of using these drugs in persons with dementia, antipsychotics come with a black box warning specifically for this population. In 2008, the U.S. Food and Drug Administration mandated that antipsychotic drug manufacturers add black box warnings to labels and prescribing information because of the link found between antipsychotics and an increased mortality risk in elderly dementia patients. with high prevalence rates of antipsychotic medication use in nursing homes, in 2012, CMS launched a national quality initiative to reduce antipsychotic medications in nursing homes called the National Partnership to Improve Dementia Care in Nursing Homes. The partnership's mission has been to provide better, person-centered dementia care, leading nursing homes to eliminate and prevent the off-label use of antipsychotics in long-stay nursing home residents. At the end of 2014, and CMS has since increased this goal to 25% by December 2015 and 30% by the end of 2016. Each subsequent national goal has also been achieved. CMS has now set a new goal for an additional 15% improvement by the end of 2019 for all nursing homes identified as late adopters. Nursing homes that are unsure if they've been identified as a late adopter should contact their QIN-QIO state nursing home lead, and contact information will be provided at the end of this webinar. I'll also add the list of contacts in chat. Since the launch of the National Partnership to Improve Dementia Care in Nursing Homes, I'm jumping ahead with my slides. Hold on one moment. Since the launch of the National Partnership to Improve Dementia Care in Nursing Homes, significant reductions in the prevalence of antipsychotic medication use in long-stay nursing home residents have been documented, as you can see here on the slide, where we've included improvement rates and current prevalence rates across New England. Nursing homes across New England have worked towards enhancing the quality of life for people with dementia, implementing innovative, person-centered care practices that ultimately reduce antipsychotic medication use, including programs like Oasis, rehabilitation therapy, hand-in-hand, and music and memory. However, as you can see on this list of where each state ranks in comparison with other states across the country, there is still an opportunity for further improvement. And the folks from Franklin County Rehab are here today to talk more about their music and memory program, which has helped significantly reduce the unnecessary use of antipsychotic medications in their facility. Annette, Miranda, and Alita, I'm going to turn it over to you now.
Thank you.
You should have the ball now to advance our slides.
Good morning, everyone. I am Annette Blanchard. I'm the Director of Nursing here, and I'll just have Miranda introduce herself and Alita.
I'm Miranda Sayer. I'm an RN. I'm going on my 4th year here, and I will be moving on to Director of Nursing in the next week or so. I have 27 years of long-term care experience.
Good morning. My name is Alita Scott. I have 23 years of nursing experience long-term care, and I've been here at Franklin County Rehab for 7 and currently work at the staff development office.
And we are going to do a combination of talking throughout the slides, so you'll hear from all of us throughout the program. So a bit about our facility. We are a 64-bed facility. We opened our doors in 2014. We have 20 designated private rehab rooms, 44 long-term care beds. Our average occupancy is about 90 to 94%. Our average census, Medicare is about 27% of our census, self-pay about 21%, Medicaid is about 50%. Have a memory care unit as defined by CMS guidelines, but we do have a significant population of end-stage dementia residents.
Currently, we only have 2 residents on antipsychotic. One of them is a patient who is here for rehab. The other is long-term care. And that's pretty much been, we've had a low number for the past 3 years anyway. I'll get more specifics of that later, but we have been successful in reducing that rate to have only that number of people right now. And, of course, this program's been significant in achieving that. Quality is important to us. The AHCA National Quality Bronze Award is something we received in 2016. We are a 5-star rated facility. We participate in advancing excellence. Data is collected through we input data for people who are receiving antipsychotics. Examples of residents who wouldn't go into that program are actually the ones who have a corresponding diagnosis that's acceptable. So in other words, if somebody has schizophrenia, bipolar disorder, they're not going to go into our numbers of people who are on antipsychotics, who would be preferable that they not receive that medication. For example, giving it to somebody with dementia with associated behaviors, although it's done, it's not the goal, obviously. We participate in Abacus. We have a program that meets every Tuesday, a coffee program. It's a quality, what's the word I'm looking for? Basically, quality measures, things that are going to affect our 5-star rating and our care to our patients. We meet every week and go over this type of information, who is on antipsychotics or whatever the measure is we're trying to do. But this has been part of our, one of the subjects we review consistently to make sure that our numbers aren't going up. And if they are, that it's for justifiable reasons. We had a deficiency tree survey for 2016 and 2017. In 2012, our facility administration committed to participating in Vermont Healthcare Association training on Oasis and reducing antipsychotics in Vermont. Oasis uses an interdisciplinary approach to care that emphasizes patient-centered care. Focuses on the strengths, the wants, the needs, and personal goals in addition to healthcare needs. It addresses challenging behaviors by focusing on understanding and addressing residents' unmet needs. So music and memory is just one aspect in our overall effort.
A little bit of the history of music and memory. In 2006, Dan Cohen's brainstorm. He reportedly came from his own desire to listen to his favorite music from the 60s. If he ever was admitted to a nursing home, he had a unique background in social work, technology, and education. He learned that of the 16,000 nursing homes in the U.S., none were using iPods. In 2008, he received money from the Shelley and Velma Rubin Foundation to purchase 200 iPods and expand his program on a larger scale. In 2012, the music and memory program spread even further with the video Alive Inside. If you're not one of the 11 million people who have seen this clip of Henry, you should do so after this webinar. It's really indescribable. 2008 was when he took his test to a larger scale. 2012, he released his Alive Inside. 2013, the Wisconsin Department of Health launched the Music and Memory Initiative. In 2015, 11 states, including our state of Vermont, made public policy statements. And today, music and memory is spread throughout the U.S., Canada, and Europe, and elsewhere in the world.
This is Sarah. I apologize to interrupt. We're getting some feedback that we need you to speak a little louder.
Okay. Thank you. We'll do our best.
Sounds good already.
Okay. All right. So just a bit about the development of our program. We had a small group form to work on developing our program, and that started in 2013. We sent several people to a workshop that they had in the state regarding Oasis and Train the Trainer, and regarding the reduction of antipsychotics. We started training our own staff in 2013 and 14. We did this through in-services on the Oasis modules, and obviously the risks and benefits of using antipsychotics in the elderly population. One caveat is change is very hard, and it's best to start small and slow when you are making any changes within your facility. We began planning for music and memory in 2014 with a formal introduction of the music and memory program in the spring of 2015. Challenges and barriers with starting the program. Change is very hard. Staff are very set in their ways and their routines. Staff have to buy in before any change will work. And, you know, they usually say, why do we have to change? We don't have time to learn about Oasis and music and memory. No time to leave the unit. We don't have time to get to know each resident's unique needs. Those were some of the things we encountered along the way. You have to really change the way of thinking from a facility-centered program to a resident-centered. Our toileting schedules versus the residents. Our sleep schedules versus knowing the resident's personal history. Education is the key, getting staff to understand that they need to recognize each resident's unique personalities, interests, strengths, and challenges. Another challenge that we had was where to incorporate this in the electronic medical record, how to document the behaviors, how to document the use of music and memory, and how to describe if it was effective or not. Staff were initially worried about behaviors, but they were excited about having new tools to work with. We learned that if staff understood the benefits and why we were trying these new things, that they had an easier time buying in. I think that once staff feel empowered and they understand that they are making a difference and they see the examples of working with the residents individually, then that helps them buy into the program.
For our training, we did do, as Annette mentioned, the trainer on the Oasis module. We used this method to spread Oasis principles using key staff, our social workers, senior LNAs, enrichment staff, and charge nurses. Initially, we chose pieces of the modules and used the most bang for the buck to begin the training with. Behaviors are definitely a sign of unmet needs. And then we carried on at least annual training for dementia care. Some areas that we have done and focused on are eating with different diets and utensils, virtual dementia tour, music and memory and aromatherapy program and its effectiveness, person-centered care, walk in my shoes, power of labels, Mr. Jones, not the man in 213, case studies, and training on dementia and Oasis training also occurs at orientation as well as annually, and when working with specific resident needs from interdisciplinary approach. So why does music and memory work? So our brains connect music with long-term memory. The limbic brain, the primitive brain, is the major center of emotional stimulus for music and remains intact even to late stages of dementia. I know there's probably a lot of 80s folks out there. I know whenever I hear the 80s music comes on, it takes me right back. So, other areas remain intact: emotional memories, motor memories, understanding of facial expressions, and tone of voice, rhythm, singing, and automatic speech.
So what is important when you're starting a music and memory program? You have to make the music and memory impact the resident's identity, and it uses their own favorite music. It is a connection to the outside world and the elder's own history. The choice of music supports the elder's own security, and music has meaning as it is tied to the life they have experienced and choices they have made. The benefits of music and memory: happier and more social elders, stronger and deeper relationships between elders, staff, and family, calmer and more supportive environments, lessened burden on care for staff due to increased behaviors, reduced reliance on antipsychotics and anti-anxiety medications, decreased refusal, which increases attention to tasks, increased reminiscing skills and verbal output, increased ability to access spontaneous movement.
Several of our residents would get very anxious during bathing in care, but staff learned that if they sing to them during care, that would actually help to calm them down during bathing. We also had another resident that would cry out frequently during the day, but after music and memory came into place, they would frequently find her humming in the hall with her headphones on. Several residents have improved intake and appetite if music is playing during their meal.
So what we did to roll out our music and memory program, we did purchase our own equipment. Some facilities, I believe, have gotten grants to do this, but we purchased our equipment. We purchased iPod shuffles, which are the little tiny iPods with headphones and chargers. We have, I believe, about 24 of the iPod shuffles in our facility. We have a laptop specific for loading music onto the shuffles, and we really just use iTunes accounts or other music websites to build the music library for each resident. We chose a core team of designated staff to start the program. We had a team leader, definitely a tech person who's familiar with the iPods and downloading music. And that was somebody in our enrichment program who took on that role. And then you need someone who's very comfortable and has good communication skills to interview the resident and find out what music they would like. And they have to have bought into the music and memory program. We started very small. We chose about 4 or 5 residents to focus on that had behaviors, anxiety, some social withdrawal, and failure to thrive. We did ask people to give us $20 donations for used iPods, so we did get some that were used when we started our program.
This is you can speak a little louder.
Sure. Choosing the music is key to success. You have to involve the resident and the family if the resident can't tell you, and ask lots of questions. What did they listen to with their parents or sing to with their kids? Their favorite song, artist, or type of music. And you don't want to, load all the Billy Joel songs and just use Billy Joel songs. You really want to have a variety. What was their favorite music? Was there a music from a song or a wedding or an anniversary or a birth of a child that stood out for them? Did they listen to music while they were working? Were they a teacher? What did they do for work? Did they have favorite hymns or spiritual songs? Did they sing in a choir? Did they have favorite holidays? Was Christmas their favorite holiday or maybe Halloween? And again, use variety. Don't just download one type of music. If they like jazz, you don't want to just download jazz. They may have some other things. Really get to know and learn about the person.
In April of 2015, we had 3 residents participating in the program. By June, we had 7. August, 9. Kick it out a year, January of 2016, we had 18. I don't need to read all the numbers to you, but as of right now, we have 21 residents who participate in music and memory.
So how are we maintaining our success with music and memory? Our staff now think of music and memory for basically any incoming resident, whether they're a rehab resident or a long-term care resident. is addressed in every care planning meeting for any resident who may benefit. I find that music is a big part of our enrichment program. We have a weekly exercise program with music. We have Zumba. We have a resident choir for holidays, and we have weekly ongoing musical guests in the facility, anything from accordion to piano to singers. We have lots of music in the facility. We do try to think outside of the box and incorporate music into person-centered care, not only through the use of iPods and headphones, but by using music in CD players, movie musical choices, playing music during care and before bath and shower days, and encouraging staff to sing while providing care. Our families play an active role in resident care, enabling us to really provide person-centered care. Families are invited and encouraged to participate in care planning, facilities, programs, and activities, and our true presence in the facility.
So when we start looking at people who are taking antipsychotics, and we have people that come in on them, or maybe a doctor has prescribed that while they're here. But typically it's people that have come in on them, to be honest. So one of the first things we do is from a clinical standpoint, we're going to review their medical data, look at the laboratory data. We're going to make sure they don't have an infection, that there's no medication interactions going on. Obviously in long-term care we have people with, they're pretty medically complex. They're on multiple medications. We try and reduce polypharmacy as much as we can. So that's one of the first steps. We want to make sure they're not in pain, they're not ill, there's nothing new going on. Ideally, we'd like to get a psychiatric consultation done if we can get somebody to come in and do that. Sometimes we take them out for that. And that's one of the first steps in looking at how we might reduce the antipsychotic rate. So we're going to address the source of, basically we're going to address the unmet need. It's a bit of a different way of thinking. We're not just trying to take care of a behavior. We're trying to figure out what it is the patient might need. So we're not chemically restraining somebody, for example. Interventions have to address the individual needs. Music and memory is one of the interventions. Some of the other ones include our restorative nursing program, where we have LNAs who have been trained by our therapy team, and they help the residents maybe they help them with mobility, or if the person can't walk, assist with other forms of exercise. We have walking programs. If we are going to have somebody who is having behaviors, we're going to do time studies and see if they're always having increased behaviors around the time they have to use the bathroom, or they like to nap at certain times, or be up. Maybe we have people who work nights, and so they're up a lot at night. So instead of trying to just continually keep them in bed, we try and engage them in ways that are relevant to them. We have our therapists who do evaluations for us. They come up with care plans that include meaningful activities for that individual, activities that are resident-specific. For example, we had one resident, and she had behaviors that included throwing items across her room, hitting staff, hollering out frequently, threatening to put herself on the floor, and then she would put herself on the floor too. She would refuse meals, refuse care. You couldn't reason with her, obviously, and many times. So our activities department and our therapy department all got involved. This lady had been a teacher. She loved art. She loved music. And so with the implementation of the music and memory program, and with the activities department, sometimes just doing one-on-one activities with her. She would end up doing art in her room with activities. Sometimes she would join the any of the art programs they were doing with groups. She would sit by the fish tank. We had a counselor come in from MCSS, and even if she didn't want to talk, sometimes she would sit there with her. Obviously, that ideally we would want her to, engage in conversation that was meaningful to her. And she would talk about her teaching and the kind of things that she could remember and that were of interest to her. Sometimes it amounts to the patient needs some time to adjust to their stay before you could even consider decreasing an antipsychotic. So if we have people coming in on our rehabilitation unit and they're on an antipsychotic, the first thing we're going to do is not going to be to try and reduce something that they've probably been on for quite some time, and they're not going to like the idea of reducing it. But eventually, if they're here long enough, we will introduce trying to do a gradual dose reduction, obviously taking into consideration, their doctor's recommendation as the diagnosis. And we have been successful with that. A lot of the patients have emotional triggers. They've experienced a lot of losses, a loss of independence, loss of family and friends, loss of mobility, for example, if they've had a CVA. So there's a lot of emotional triggers for these people, life changes. So our music and memory and the other interventions I mentioned, we try and address all of it, really get a big picture view of this patient in order to be successful in reducing antipsychotic use. So reducing antipsychotic medications, it involves the entire interdisciplinary team. It's part of the team that meets every Tuesday, part of our coffee program. And that includes nursing, our physical therapy department, our activities department, administration, social services, and dietary. We use psychiatric services to hopefully get an accurate diagnosis and treatment. Sometimes that's hard when you have people with dementia who can barely speak, but they're still very useful. And of course, like I said before, counselors are often effective, even with dementia patients who don't speak a whole lot. But when they do, they speak of what maybe they remember, subjects that remain relevant to them. And staff does eventually buy in as they witness the success of the program. We do consults to DRX counseling services. We don't always wait for evaluations and recommendations because obviously we're getting to know our residents upon admission and continuing. We listen to the LNAs, the staff on the floor, the people who interact with them the most, also have a lot of input into what, insight as to what these residents might need. Gradual dose reductions, you have to involve and educate residents, family members. Sometimes the physician who may be prescribed the medication isn't the primary care physician at the time. So often, there's visits out to neurology or other specialists, and we talk to them about dose reduction as well. We work closely with the pharmacy to reduce doses carefully and slowly. We involve the staff prior to reduction. We pay attention to how residents react. We monitor the target behavior. We provide reminders about individual triggers and approaches. For example, bathing without a battle is a program that we've had some of the nursing and LNAs watch because, a lot of people are triggered when you're trying to undress them and bathe them for whatever reason. So bathing without a battle is an example of an approach where you can meet a need and decrease
decrease the behaviors, hopefully. Another part of reducing this and making sure that we have to make sure that documentation is being done correctly and addressing the behaviors that are in the electronic medical record. We found that hospitals are now less likely to use antipsychotics during an acute stay if they're considering rehabilitation, transfer from the hospital. As far as pharmacist involvement, I think most facilities probably have pharmacist consultants. We have a pharmacist that we work specifically with through the pharmacy that provides our meds to us, and they've been very helpful. An example of something you might expect from a pharmacist is we had a patient who had pseudobulbar effect. So basically that's a neurological disorder where there's the way they express their emotions is it's sudden involuntary expressions of emotion that are disruptive to them, and it can go from, like the lady that I'm thinking of, she would go from crying to laughing within 1 minute, and it would go on, and you could tell the woman was very anxious and very upset. So we were, after all of the other stuff that I've spoken of, ruling out medical issues, having, psychological services come in, we ended up talking to one of the pharmacists, and he said there was a medication called Nudexta. It was a newer medication that could treat this kind of, this medical diagnosis. But it's new, it's very expensive, and insurance didn't cover it. And so it ended up being that the pharmacist said it's basically 2 ingredients in that medication were dextromethorphan, which is a cough syrup, and quinidine. We ended up giving the patient the dextromethorphan. The pharmacist helped recommend a dose, spoke with the physician, spoke with the nursing, and it eventually did help this patient. So that's just an example of how you can get your consultant pharmacist involved. In 2012, quarter 1, we had about 20 patients who were using antipsychotic medication. 2012, quarter 4, there were about 25. So that's about where this graph peaked. If you just read down the graph, you'll see the numbers continue to gradually reduce. So 2017, quarter 3 is where that ends. And like I said, right now, we have 1 long-term care patient who's using an antipsychotic and 1 rehab patient, and that's it. So we have some that come in, and if a person has a diagnosis of schizophrenia, bipolar, the ones that would justify use, those aren't the people we're doing gradual dose reductions on. We're doing gradual dose reductions on people who have been prescribed this for behaviors or anxiety, depression that's not necessarily related to the diagnosis which justifies use according to CMS.
Successes of antipsychotic reduction. We certainly use them as a last resort when all other interventions have been exhausted, and only with the approval from administration and our medical director. We definitely discuss at our interdisciplinary team meeting and care plans for residents before we even consider using these. Staff have seen changes in resident status with dose reductions. And certainly we've tried dose reductions on one of our residents that then we did know increased behaviors, so that we did turn around and continue back to the previous dose. When we did do a trial. More participation in social interactions, more aware and happy. People have gained some functional status as well. They do become empowered, but they're making a difference. So now we're beginning to think other interventions before utilizing any antipsychotic or psychoactive medication.
So the challenges to sustaining the program, staff turnover is a very difficult thing. Long-term care is a moving target, and yes, you may have just done education on dementia and Oasis and Antipsychotic 6 months ago, but now you have 15 new staff members, and you have to do it again. So you have to repeat the education. Of course, the ever-changing regulations impact how you can sustain a program. You kind of divert your energy to working on the regulations and making staff understand them and making sure you're meeting them, but that does take away from continuing your work with the other programs. Healthcare delivery system and the increased acuity, we are getting more and more people coming to us with higher needs, and that also impacts how we can continue to sustain the program. Technology updates are always happening. Just when you get staff trained on the electronic medical record, there's an update and how they document changes. And again, that is time-consuming, and you have to do education all over again. Documentation and complacency with it can sometimes be a challenge. We have very good documentation for our music and memory program. We have choices of what they use the music and memory for. Was it effective, and how was it effective? And sometimes we'll see that staff just put that they used it and don't answer the rest of those questions. Maybe because the staff are new and they don't know the pieces of all the documentation, or maybe they are just too busy to do that documentation, or they just are not wanting to. So that can sometimes be a challenge. And certainly, thank you for letting us share our story, and we are here to answer any questions. And I'm going to turn it back to Sarah.
Actually, you can pass the ball to me, Doreen.
Okay.
Thank you for a great presentation. At this time, we'll take some questions. If you'd like to ask a question over the phone, please press #6 to unmute your line to speak, or you can post your question in the chat box. Remember to send your post to all participants.
Doreen, we don't have any questions in chat at this time. We did get a few questions earlier about getting the slides, and I am resending the link.
Yeah.
The link that was working earlier. The slides are now up on the website, so if folks want to click on that link, I'm going to put it in chat right now. You click on the link, scroll down, and you'll find how to download the presentation slides.
Okay, we do have a question. How does your activity staff document residents' participation in the Music and Memories program?
Now, Doreen, can I just speak? I guess I can, right?
Yes, you can.
So we use American Health Tech as our electronic medical record. Our LNAs have access to the computer for their documentation. We have, I guess you would call them buttons on their documentation for music and memory and aromatherapy, and it's a point-and-click system. We have music and memory built into really all of our residents' care plans, but certain ones are on the program. So say they used music and memory during a bath for Mrs. Jones. They click on music and memory, and it will say, did you use music and memory? They answer yes, and then they click on why they used it to calm residents during care, and then they click on was it effective, and it says yes or no. And then we can we have a report built so we can print off who is using it, what are they using it for, and is it effective.
Great. Sarah, I can take this. We have another question. How do you track the iPods so they don't disappear?
So that is a very good question. We have, our enrichment department created these little bags that have all their supplies for music and memory in it, and we try to train the LNAs that that bag goes in one location inside the closet in their room, and there's a little charger that goes with the iPod. I'm not going to say that some of them haven't been found in other places, but it's really just reteaching and educating that their music and memory bag goes in one place, and this is where you find it.
Great. We have another question from Laura. Have you ever had a consult with a board-certified music therapist?
I do not believe we have, no.
Okay. From Dina, we have, what grant did you access to obtain money through this program?
We did not access any grants, but I do believe there are some available. We felt that it was an important program and purchased the iPod shuffles ourselves.
Okay. Do we have any other questions? Well, thank you all for a great discussion. I have a few last announcements before we end today's call. On this slide are our local contacts for your state. Please make sure to reach out if you have any additional questions or you need support. As you close out of this webinar, the evaluation will automatically appear on your computer. If you could fill it out, we'd greatly appreciate it. And if you don't have the time to fill it out, or you're sharing a computer with someone else, you'll receive an email tomorrow with the link to the evaluation. Also in the email tomorrow, you will receive a link to the event page on our website. The PowerPoint presentation is currently posted on the website, and within the next few business days, a recording and transcript of this webinar will also be added. Thank you again for attending. Have a wonderful day.